Thank you, ladies and gentlemen. Thank you very much. Just call the meeting to order. Thank you for all giving the time, as I've clearly a very strong interest. I just want to introduce myself first. My name's Andy Wright, and the reason that I'm here is to act as the independent chair. So it's important to stress from the beginning that I neither work for the NHS, live in the area, or work for Freshwater, who are the communications company that are running this consultation. So I'm totally independent. So my job today is to make sure that everybody gets a fair hearing and they have the chance to speak, and also to ensure that the panel get the opportunity to speak as well. As we're going through this, I welcome tough questions. So you might have some really strong stuff to say. But while we're doing that, I don't believe in ground rules in these type of meetings, but the only thing that I would ask you, well, two things in fact. First, that we treat each other with respect. We allow people to finish speaking before you ask a follow-on question. You also allow the panel to complete their comments. And the other thing is, this meeting is being audio recorded, which is why we've got professional sound in, and it's being audio recorded as part of the formal consultation process, so this forms part of the evidence. So as we're going through all of this, we're going to ask you to put your hand up for a question and wait until a microphone arrives for you. I know it's a small hall and we can hear each other, but it's just to ensure that it's actually recorded on the evidence. Now, there's a very important point for that, because if you just shout out your question and it doesn't get recorded, it might be the absolute most important question that's asked this afternoon. And if it doesn't get recorded, it doesn't go into the evidence. So we'll have some answers, but we won't be able to track it back. Or, sorry, the people that analysed the consultation won't be able to track it back. So a little bit of patience while we move it round. So we'll have the guys from the audio team running round, give them a good cardio workout. It's part of a healthy living exercise. And while we talk about hearing, I'll just make the point that there is an audio loop round the buildings, around the hall. So if anyone that does need hearing aid assistance, that's on for you. And we also have a signer here for anybody who's hard of hearing or deaf and needs assistance with that. Okay, so it's all good, I hope. So, just to check we're all in the right room at the right time, we're here today as part of the consultation exercise to discuss the future of healthcare in West, North and East Cumbria. So this consultation document is available if you haven't had the opportunity to read it. And I just before we get into the formal proceedings, I know a lot of people will feel confident in speaking today, some people won't. And in this document, which is also available in Braille, Easy Read and in other languages, in this document at the back of it, there are all the ways in which you can be involved in the consultation. And I should just have added that I'm employed by the Consultation Institute, which is a totally independent body. That's the bit I forgot. Domestics, we're not expecting a fire alarm, so if there is any such alarm, clear out through the clearly marked fire exits. If I would like you to congregate in the garden outside to just make sure that we've got everybody out, and then hopefully that won't happen. And toilets are back that way. We're all grown-ups here, so if you need to use the facilities, they are in the entrance area as we came through. So really, that's the proceedings. What I'm going to do is ask for the panel, or specifically Debbie, to give us a presentation about this. So if you just listen to that, and then hold your questions, and then we will open the floor to take as many questions as you wish to give. So I'll hand over to Debbie, and thank you all.
Very much. I suspect I met some of you some months back at a similar meeting. I certainly recognise some faces in the audience. So thank you for coming out again to listen to what we've got to say. To ask questions. We might all need to jog around the room, I think, in a few minutes, because it's actually a little bit chilly. But I hope you'll all stay warm enough for the next couple of hours, and we don't create too much hot air up at this end of the table. Right. So the consultation itself, NHS Cumbria, the clinical commissioning group, has actually got the legal responsibility for leading the consultation. That's a national issue that is their responsibility as commissioners, but actually all of the work that has gone on in the run-up to the consultation has been through close working across all of the NHS organisations across West, North and East Cumbria, and also with the local authority and the success regime. And I think it's really important to note that when we talk about the success regime, people think about people being parachuted in from London to tell us how we ought to be running our services, but actually the success regime is ours. It belongs to us all, including local people, and it's for us to try and tackle with expert help from outside some of the really difficult issues which we haven't necessarily managed to solve in the past. The outcome of the public consultation is a very important factor in health service decision making, but there are other factors as well. So I think on the next slide it talks about it not being a veto. So we need to take into account what the public, what our patients and communities tell us about some of the suggestions and proposals that are being made, as well as the clinical aspects, the financial, and also the practical considerations of delivering services. So it's really important to note that no decisions have been made, nothing is predetermined. This is a consultation, and we're here to listen to you and to take on board what you tell us. Everything that goes into the consultation in terms of your comments are gathered up. I think, as was said before, that part of the decision making means that everything that's said today through the microphones, everything that's posted online, any scraps of paper that are posted through the Royal Mail, all get put into the decision-making exercise. They're all independently analysed, and those will then form part of the decision-making process, again, that is led by the clinical commissioning group. And there won't be any decisions until next spring, when, following the end of consultation, just before Christmas, in that time after Christmas, there'll be this very thorough analysis of what the consultation has told us, and further consideration, therefore, as to how proposals should be taken into the decision-making point of the exercise. So why are we doing this at all? Well, I think, as I said to you, many of you last time I met, well, we've got some really big challenges here. So population health isn't good. We have problems nationally due to the fact that we've been so successful in helping people live longer and live into old age with many more years of life. But that in itself has a toll, in as much as people are sometimes living with long-term conditions which need support. Families are further flung. There's not the same ability to provide that support as perhaps there was some years ago. And in this part of the world, we have what has been dubbed a super-aging population. So whilst nationally there are increasing numbers of older people as a proportion of the population, here it's even more so. So we have, therefore, to contend with the challenges that brings. There's some real upsides, but there's also some challenges in terms of delivering health and social care and making sure that the resources go round. We've also got some really significant pockets of disadvantage and deprivation. There are areas with high levels of child poverty. There's problems in relation to childhood obesity, to use of alcohol and substance misuse. So there's lots of challenges there for our particular population. Coming back to the national context, of course, there are lots of new technologies and financial pressures across the whole of the NHS, which we need to bear in mind. So that affects everywhere. And if you've been following the progress of the NHS nationally, you'll know that many other areas are also talking about their STPs, their sustainability and transformation plans. And what that means is their local area plans, like we're talking about here. Everywhere is starting to develop a local plan. For once, we're actually in a very fortunate place, because of the success regime, because of the challenges that we faced, we're actually further ahead than many of those other areas and have undertaken a lot of engagement, a lot of work with clinicians, with members of the community to develop some of the proposals that we're talking about today. We have real difficulty in attracting doctors, nurses, and some of the other health professionals. Part of that is because of the way in which, in particular doctors, but also some other specialist areas, now increasingly work. So gone are the times of Dr. Finlay and Dr. Cameron in general practice. People organise more into larger practices, and even within those practices there is a degree of specialisation. So you will see one doctor taking on responsibility for perhaps diabetes clinics and another managing antenatal and child health. And that's increasingly normal within the NHS. We also see in hospitals that doctors expect to be able to work within wider teams where they have the ability to develop some specialty interests. And that means that in general they want to work in large teams with less onerous on-call rotas, and also they often during their career want the opportunity to move into other hospitals in other opportunities without the need to uproot their families, their children from their schools. And that does put us at a disadvantage in this part of the world. We tend to see much of the available staffing going into areas further south, and then when the staffing does come to the northwest and northeast, and we count within the northeast, bizarrely, for workforce numbers, that staffing that does come in often will be attracted to work in Newcastle or in Manchester and won't want to come as far afield to rural areas such as this. And it's just a fact of life, but unfortunately it does mean that when there are national shortages in some areas, and there are a number, that we are at the end of the line, and we therefore need to desperately come up with solutions that make us an attractive place to work and not as somewhere that's seen as not going to be delivering the career aspirations of doctors and specialist nurses. So we've got big vacancies in some of our areas. In primary care, we've got 19 doctor vacancies at the moment. Lynn's the expert on all this. She can tell you some of the numbers later, I'm sure. In nursing, we've got a large number of vacancies. We're all fishing from the same pool across nursing homes, community nurses, acute hospital nurses, community hospital nurses, and there aren't enough to go around. And we have consultant vacancies of something in the order of 25%, so significant number of gaps within our consultant teams. Not forgetting that it's very difficult to then provide two teams across two different hospital sites so far apart. We know that we've got too many hospital admissions, we've got long stays. When we have done pieces of work to look at individual patients and say, is this patient in the right place? Often we have found that they're not, that their care would be better managed in another setting, better managed in a community hospital than in an acute hospital bed, or better managed in a community setting altogether than in a community hospital. It's not good for you to be in a hospital bed. We know that it reduces levels of mobility and independence. So we don't want to place people into beds when it's not necessary, because it's actually physically and demonstrably through research evidence not good. NHS is significantly overspent, and that's particularly so locally. So we're about £70 million overspent across the partners at the moment. That would rise to something in the order of 163 million if we were to do nothing. And that means that we need to ensure that we deliver care as efficiently as we possibly can. However, and I'll stress this again later, the changes that are being proposed during consultation are not being driven by finances, because what they actually deliver is a very, very small element of the savings that we need to make. So the changes that we're proposing are being driven by quality and safety and operational issues, not by finances. The Care Quality Commission, the CQC, has found some of our services to be either inadequate or to need improvement, and in particular made note of acute medicine, in other words, medicine for acutely unwell adults at West Cumberland Hospital, and said that that was inadequate. We're also not meeting some of our core standards in relation to cancer standards, A&E waiting times for planned care. We know that all this uncertainty going on for many months and years actually does nothing to help the situation. It doesn't help our staff and their morale. It most certainly doesn't help you in concerns about what's going to happen to your health services, and it doesn't help. I've lost it for a minute. Oh, it doesn't help recruits. That's what it doesn't help. It doesn't help people who we may be able to attract into the area. So it's really time that we tackle some of these difficult issues, and we need your help in doing so. It's really important that we actually start to develop services in conjunction with yourselves and not in a darkened room and then tell you about it afterwards. So we are wanting to very much more engage local people and communities in how we develop and design services. There's been a lot of work that's gone on over the last year to engage people. We probably haven't gone far enough. We've got further that we can go, but it's really important that in moving forward that is absolutely core to what we do. So what we're talking about now actually builds on previous work, and it is about modernising our services. We can't live in the past. We've got to make sure that we have services that are fit for the 21st century and are not based on what used to be okay as standards 10 years ago, because some of those standards are no longer okay, and we should be expecting more of our local services. So we have come up with what we hope is a compelling vision. We want to create a centre of excellence for joined up or integrated health and social care across our rural, remote and dispersed communities. So dispersed, recognising that many of people actually live in towns, but they still may be an awful long way from other centres, particularly for the most specialist care. We want to become known not as a health system that's actually struggling all the time, but as one that is an expert in delivering health and care in these remote and rural settings, so that we can attract doctors and nurses who might not at the moment be thinking about coming here, that they think, yeah, that's a really good place to go. You know, they're really well known for how you can deliver care in remote settings. And that is absolutely what we want to develop as our USP, our particular mark that we're going to, our selling point that we're going to promote. So we need new ways of working, we need new approaches to the workforce, and we need to be importantly doing that together, joining up all the pieces across all of the health organisations, social care organisations in the northeast, where we look to for our specialist services for the north of the county, and also with academic partners who can help us do some of the action research that actually proves the evidence of what we're doing here as cutting-edge medicine in remote areas. So that's our goal. We want to become a really great place to work, a centre for learning, and one based on teamwork and modern practice. At the heart of what we want to do are integrated care communities. Again, I think we've talked about this before. So this is about delivering joined-up care to communities of between 20 and 70,000 based around the populations registered with their general practices. We have 8 integrated care communities at different stages in their development. This is not something that is here for consultation. It's something that we're doing anyway, but it is so fundamental to delivering all the other things that we think it's really important to talk about it. It brings together all of the health professionals involved in helping people stay independent and keep well and stay out of hospital. We know that GPs are really valued in what they provide, But sometimes other things go wrong, and people often tell us about how care breaks down because you have to tell things 17 times over to different health professionals, and nothing actually seems to get communicated across the system, and we don't plan in advance. So instead of actually having a clear plan for what happens if somebody becomes a little bit less well than usual, we end up having to admit them into hospital at nights or weekends. And these are all the things that integrated care communities are intended to try and address. So we want people to stay independent for longer, not needing to go into residential and nursing care, reducing the need to either go to hospital at all, or if you do need to go into hospital for a stay, then coming out much sooner, and making use of all the technologies that we've got so that we can perhaps have video links, that we can use what's called telehealth and telecare to help monitor people's progress within home settings or GP surgeries. So, our integrated care communities, along with other elements of change, are designed to create us with much safer services of higher quality, and really importantly, things that are clinically sustainable, that they can see us into the foreseeable future, that they are not prone to collapsing at any one point in time. I talked about workforce earlier. I mentioned the large number of, for instance, consultant vacancies. We have to fill those vacancies. We don't fill them all, partly because we can't. We have to fill those vacancies with locums, with temporary staff. They are not only very expensive, but also they come and go, and they come in and they do their job and they go away again. Some of them are excellent and have stayed with us for some long time, but others are more transient. And as part of their job, it's not there for them to provide the sort of leadership that developing and modernising our services requires. So we're also lacking in leadership, as well as just the hands-on, everyday ability for the workload to be managed. And that's really important. Financially sustainable, they clearly need to be financially sustainable as well. One of the difficulties with locums is, of course, that they're extremely expensive for one reason or another that we can go into later if you would like to, but they are very expensive. We try and control those costs as far as we can, but it is difficult and it is a drain on our resources. The Chief Inspector made it quite clear when they visited last April and reported over the summer of last year that our reliance on locums within the hospitals was utterly unacceptable and that had to change. So a core part of what we need to do is to address that. So what are the service changes that we're consulting on? I'm going to go through these quite quickly. They're all within the consultation document, and I've seen a big stack of them at the back of the room. So please pick them up, take them with you, have a good look at them. We have as a system agreed that it would be helpful for you all to know where our thinking's at. So we have identified our preferred options at this stage. That's not to say that anything's been decided. It's to say this is where our thinking's going at this particular point in the process. And those are all shown in bold within the slides as I go through. So children's services must consider the hospital services within the context of all of child health. Nationally and internationally, we expect to see much more care for children, acutely ill, suddenly unwell children, but also children with long-term requirements. We expect to see much more of that delivered in community settings. There is absolutely no reason why not. So this bit of the consultation has to be seen within that context of an expectation that we will be able to manage much more within our integrated care communities. We have some challenges within children's services in the hospitals at the moment, particularly at West Cumberland and particularly in relation to consultants. So we only have one out of the required 5 consultants at West Cumberland Hospital. 4 of those posts are filled by locum staff. So the options that we're looking at are to have short-stay paediatric assessment units at both of the main hospital sites, in option 1, supported by full inpatients at Carlisle and at West Cumberland, inpatient beds, but only for those low-risk, low-acuity patients. That's the preferred option. In the second option, it would see full inpatient care at Carlisle, but a short-stay assessment service at both sites, but no overnight beds at West Cumberland Hospital. And in the third option, only outpatients at West Cumberland Hospital. I've just spotted a typo on there, Mitch. I must speak to you about that. Let's get that corrected. Maternity services, subject of considerable review. I'm sure you're all aware of this. This is probably the most difficult issue for us all. The Royal College review, which pronounced last March, I think. I may have got that wrong. I've forgotten the times now. Anyway, the Royal College review was called because of our difficulties in delivering maternity services, remembering that it's not just about midwives or obstetricians, it's also about the anaesthetic support that is required and the paediatric support that is required. And they came and undertook a review, and they said the preference is for you to continue to provide 2 consultant-led units on both sites in the north, and they said the same for the south. However, if this cannot be done, you would need to move to another model, and therefore you need to go away and work up how you're going to deliver that over the next year, and at the same time work up the other models. So colleagues have spent an enormous amount of time trying to come up with deliverable models. And the conclusions that many people have come to, including those within the success regime, all of the local partners, and the national experts who were brought in to help us, was that we cannot continue to provide consultant-led maternity care on both sites, and that therefore our preferred model, as indicated here, is that we would have a midwifery-led unit at West Cumberland Hospital, as well as all the normal range of antenatal and postnatal care, and 12-hour consultant presence to provide emergency gynecological assessment services and all the extra consultant services for patients on an outpatient basis. The third option that remains on the table is to fully consolidate the care for women in labour at the Carlisle Infirmary, so that all births would happen at the Carlisle Infirmary, except those at the Penrith Birthing Centre and women who choose home births. That would still continue. Community hospital inpatient beds. Community colleagues have suffered the same difficulties as we have in the Hospitals Trust in relation to nurse staffing. It is very difficult to staff some of those wards where there are very low numbers of beds and therefore patients. We know that we need to look at staffing so that qualified nurses are always supported by another qualified nurse at any one time, and that there is a magic number of an expectation that there's one qualified a member of staff to every 8 patients. So that gives us our sort of building blocks, and is why some of the numbers of beds have been come up with. So basically, the options that are around community hospital inpatient beds are set out from 1 to 4. We can go through those later if you would like to. We must remember this is not about community hospitals per se. This is only about the inpatient beds. All the other elements of community hospitals would continue, and in fact, in many cases, we would expect to see more being done in community hospitals by virtue of what we're trying to do to move care outside of the main hospitals and into community settings where we possibly can. Emergency and acute care. Again, the workforce shortages, the difficulties highlighted by the Chief Inspector have driven much of what we've talked about. And again, we've spent an awful lot of time in looking at how we could continue to safeguard the accident and emergency department at Whitehaven and the beds, because obviously you can't just have an accident and emergency department, you need something behind it to manage the people who are ill. And we've come up with a model which is being seen nationally as at the forefront of what is going to happen in many other places, I expect. We've come up with an approach to workforce which we think can solve the problem that we have. The principal problem being that we have the entire middle tier of resident overnight doctors filled by locums. Not one of them is a substantive post holder. Unacceptable to the chief inspector, unacceptable to all of us. The danger of this is that that could fall over at any moment. 2 Christmases ago, 2 locums said that they were going in Christmas week. The whole thing nearly collapsed. And to have that happen precipitously is obviously extremely risky. So we've come up with a model based on developing advanced practitioners, not just nurses, but paramedics, intensive care nurses, lots of different types of professionals who could train up not just to a junior doctor level, which is what we've already really successfully done at Whitehaven, but to the registrar level, the middle grade doctor level, so that we have grown our own cohort of doctors who, supported by the A&E doctors and the intensive care doctors at Whitehaven, could form what we call this integrated front-of-house workforce to help manage acutely ill patients. So that's the plan. We think that we can do that, and that's why our preferred solution is to maintain the 24/7 accident and emergency department on both sites with medicine. It also means in all of these models, but particularly critical for this first one, is that we manage as much care on an outpatient basis and during the daytime as we possibly can. So there's less happening at risky periods overnight and at weekends when staffing is generally less. So in all of the models, we have what we call hot clinics to be able to access speedy advice from specialist doctors for health professionals, frailty assessment clinics, ambulatory care, so that we can have a system where we actually proactively manage ill people rather than waiting for them to come in because the GP can't manage things any longer at home and they suddenly pop up on a Friday night. Not great for patients. Even worse for their relatives, I suspect. So that's what we're wanting to do there. The other options talk about reducing the A&E presence to only daytime, and that would mean we could only admit certain types of patients. And in the third option, actually only having an urgent care centre on the West Cumberland site and having full A&E and full medicine only at Carlisle. Not our preferred options. We think we can manage. Hyperacute stroke services. Hyperacute refers to the first 48 to 72 hours immediately after the onset of a stroke. In the model, very important to stress, and I know my colleague is going to pick up with a lady in the audience who's raised a particular issue about stroke. In the model that we're looking at, although we're consulting on this first element, part of integrated care communities, part of what we're intending to do around stroke is to make sure that we have much more robust and comprehensive early supported stroke discharge so that patients can be supported to go home with the right sorts of therapies in place, with the right support packages at home to speed up their recovery. That's a core part of what we want to see in our integrated care communities. Currently, our hyperacute stroke services are only 5 days a week. They are run by 1 and a bit consultants, and he's only a bit because he does lots of other things as well. They're both due to retire. There's a national shortage of stroke consultants. We think that to deliver the best care, we need to consolidate our stroke service provision onto one site. That's not just to do with the workforce issues, though that's core to it. It's also because we know that if you deliver care in what's called a hyperacute stroke unit, the evidence is that more patients survive and more patients manage to live independently after that. And that is the biggest contributor to people getting well after strokes. That's the biggest contributor to outcomes than anything else. Second is the early supported stroke discharge. And third is the thrombolysis. So actually thrombolysis has less impact on your outcome. That's the clot busting stuff that has to happen within a short time frame. That has less impact on your outcome than does a hyperacute stroke unit with specialist support whilst you're there for a short period of time, and then early supported discharge. Local financial position, I talked about that before, £163 million if we do nothing, that will be overspent each year by 2020. We think by making lots of efficiencies, by joining forces together around, for instance, how we buy in certain supplies, we can save up to 85 million. We think that by having less people in hospital, because we're keeping them well and managing them in home settings, we can save another 45 million. And the clinical changes that we're consulting on here only save 2.1 million. They are not the driver for what we're proposing. Future for West Cumberland Hospital. It's really important to recognise that West Cumberland Hospital is just one bit of the jigsaw. This may be of less interest to you than in other public meetings, but clearly we have just spent an enormous amount of money in building a brand new state-of-the-art hospital. It's a really fabulous place, and we intend to use it. This is not a white elephant. This is intended to be used. This needs to be our centre for planned surgery. We are undertaking 600 more cases at that site this year than we were last year in comparison between the years. We are also looking to take back elements of minor trauma and minor general surgery which had drifted up to the Carlisle Hospital. We can see how we can take that back and provide that safely within West Cumberland Hospital. We are now planning the second phase of that build so that we can provide a new diagnostic suite, finish off all the ring road and all the bits at the front. And we expect to see more people treated at West Cumberland Hospital than ever before. I think that's the end. I just want to, I suppose, just stress finally these points about no decisions have been made. This isn't about money. We've been honest about the preferred options, but they are not set in tablets of stone. They are up for discussion and change as appropriate. And our vision is about quality and safety and creating a centre of excellence here for the people who use our services.
Thanks very much for that. Right, slightly out of normal running order, two things. First of all, the lady who very kindly shared the press cutting with me earlier, if you make yourself known to colleagues after the meeting, they'd be delighted to talk in more depth around that to ensure that we answer that question. The next thing that I'm going to do is I'm going to ask, before we go to questions and answers from you guys, I'm going to ask the panel to introduce themselves and also to tell us which organisation, which partner within the success regime they represent, so that you can direct some, if you wish to, you can direct questions towards them. Okay, start at that end.
I'm sorry, I should have done that right at the start. I do apologise. I'm Debbie Freak. I'm a GP by trade, but I've been out of practice for over 12 years. I can't remember exactly how many now. And I currently work as Director of Strategy within the Hospitals Trust.
Hi, I'm Dr. Derek Thompson. I'm the Associate Medical Director at North Cumbria University Hospitals Trust.
Good afternoon. I'm Lynn Marsland. I'm Director of Workforce and Organisational Development for the Cumbria Partnership Trust.
Hello. First of all, I'll apologise for keeping my coat on, but I can see a number of you are feeling the cold as well, so do apologise. My name's Caroline Ray. I'm Director of Primary Care, and I work for NHS Cumbria Clinical Commissioning Group.
Thank you. So, as before, questions to the panel. If you could raise your hands, and I'll make sure the mic gets to you, and then so we'll take the first question, please. Lady at the front here.
The document deals with North and West Cumbria very much, and the cottage hospitals, and I can see how much work has been done on this. But how will these changes impact on us in East Cumbria, specifically the ambulance service, and also outpatient and day appointments? I'm wondering, you're saying we're taking an awful lot more over in Whitehaven. and quite a few of us, I think, are already travelling there for outpatients. That's 150 miles round trip, and we're nearer to Darlington, we're nearer to Lancaster.
If I can just deal with that point about outpatients first. So choice is an important element. So you, as a patient, can choose. You don't have to go to Carlisle, you don't have to go to Whitehaven. You can choose to go to another hospital of your preference, either because it's nearer to you or because you actually have another reason you think that it may be better for you, or somebody's recommended them to you. So that choice will continue, and that's important. A large part of what we're trying to do for outpatients is to ensure that wherever possible, that is not having to be delivered on a main hospital site. So often, there is no good reason why it can't be delivered in a community hospital site closer to where you live. Penrith has got considerable facilities, including, X-ray. Many of the community hospitals have X-ray facilities, but even within other centres, GP practices, and there's no reason why it can't happen there. So we would expect to see an overall drift out of both hospitals into more community settings. It's difficult to be precise about exactly what yet. So we know for musculoskeletal assessment that we would expect to see a lot of that within community settings. It's difficult to look at it always in terms of logistics. So we need to remember that in the same way for you travelling, it's a long time. If we start carting our doctors and nurses all around the country, we may get less value out of them if they are spending hours on the road. However, where you can manage to bundle appointments up because there are sufficient volumes of activity to make it worthwhile, there is absolutely no reason why we wouldn't do that. And we do expect our doctors and nurses, where it makes reasonable use of their time, to travel outside. Ambulances, okay. Ambulances, so ambulance service, we haven't got anybody from ambulance service with us today. They normally come to these meetings. I can't whether it's 16 now or 11 in January, or whether it's 11 now and 16 in January, but they've done 11 now and 16 in January. Lynn knows about this. They've just undertaken some international recruitment, and they, by January, will be almost up to their full establishment. I'm sure Lynn will tell you the exact details, but we don't expect to see that there would be any impact on your ambulance service to this area here by anything that we're proposing. So all the changes that are being proposed are being modelled to look at what that means in terms of people being transported in a different way, either from site to site or from their home to Carlisle. And additional ambulance has been built into the financial modelling that we've done. So it wouldn't have any impact at all.
Could you just bring Caroline in as well, please?
Hi. Was anybody at the meeting yesterday in Penrith? We had a really good example yesterday of a really good development between services that the ambulance trust offer and that Penrith Hospital offer. And in that case, there's some new equipment that's been bought and trialled that increasingly means that somebody could be treated at home by the ambulance service and you wouldn't have to make that journey into hospital. And some of the other work that we've been doing with the ambulance trust to look at this increasingly means that in one particular scheme we're operating at the moment, 80% of people that would previously have needed a trip in an ambulance to hospital can now be supported at home. So I think what Debbie's described is the impact of the acute changes and normal outpatients, but we're also doing a lot of work between all the services in the community and the ambulance service to use their skills better to stop people needing those journeys in the first place.
Can I just say on that last point, the initiative that Caroline was talking about is called a Razor Chair, and I'm not quite sure what it is because I'm not a clinician. However, that was something that was funded by the Joint League of Friends, and I think it really bodes well for all of the work that we're talking about growing ownership and collaboration at a community level, with examples like that, where there has been funding and support from people who live and work locally, supporting what the changes that we're trying to do within the health service. It really bodes well for the integrated care communities that Debbie was talking about earlier.
Can you wait until the microphone comes, please, so we get it to the record?
Sorry, just a very brief comment on that, and then I have got a question. My grandchild recently had breathing difficulties in the middle of the night. It took 45 minutes for the ambulance to arrive. The operator refused to say where the ambulance was coming from. My daughter and son-in-law could have very easily got the baby, to Penrith Hospital within 35 minutes. As it was, it took 2 hours to get him to Carlisle. So things actually aren't working very well.
Okay. There was nobody here from the ambulance service to respond to you. I apologise for that,
No, that's okay.
But it's noted. And you said you had your question.
Sorry,
Yeah.
could I just follow? I'd be interested, and again, if anybody has got a personal experience like that and would like to talk about it afterwards, I'd be very happy to do that. I think what I was trying to describe is the potential for how we can develop things, and I understand, and I think part of why we're here is because services aren't working the way we would want them to work at the moment.
No, I accept that point entirely.
Thank you.
I would like to congratulate the people who wrote this document on writing it in plain English with really a minimum of management speak and jargon. But there are 3 problems with it. In one crucial respect, it's incomplete. In another, it's actually irrational. And in a third, it's plain disingenuous. Sorry to be blunt, but it's incomplete, because although the success regime, the integrated care provision envisaged by the success regime refers to social care, everybody in this room knows that one of the reasons for the crisis in the acute hospitals is the number of mainly elderly patients for whom no social care provision can be found. And there is nothing in this document that addresses how the tension between health and social care can be resolved. So that's the incomplete bit. It's irrational because all of us would agree with the principle of integrated care communities. But however wonderfully well they operate, and however long they prolong our lives, there will come a point when every one of us will become ill and will require end-of-life care. As I'm well into my 70s, I don't like to remind myself of that. So people will still get old and require end-of-life care. And the closure of a number of community hospital beds defeats the stated objects of other parts of the document, because people in remote communities will no longer be able to be cared for within their own communities. Instead, they'll have to go to Carlisle, where they will block beds. And however good home care may be, families will, in many cases, not be able to cope. So there's a fundamental irrationality in the argument. Okay. The disingenuous bit is that the document recognizes the rurality of Cumbria, the special features of Cumbria, but blithely accepts, without any question at all, the requirements of regulators for 1 nurse for every 8 patients and a minimum of 16 patients per community hospital for inpatient beds. Should there not be a certain little bit of flexibility in this? Because as it stands, although it won't affect us too badly in Kirkby Stephen, Alston is also in the Eden Valley, is in the Eden district, and will be severely affected. And there will be a huge extra demand on ambulance services, but also on the acute hospital in Carlisle
So
through the
just-
closure
sorry.
of their beds.
Yeah, so you've got 3 questions. You've asked us about the incomplete nature of the documents, the irrationality and the disingenuousness. So we'll take them
And the disingenuous one, is another aspect of that, is that it doesn't address how, with imagination and determination, the recruitment crisis can be addressed.
Okay, thank you. Thank you very much for that. Okay, so pass it to the panel. First of all, we'll take the incomplete nature of it, if you don't mind.
I'm going to start, but you've raised so many questions there that I do hope my colleagues join in. So we'll pass it along and see how we get on. I don't think anybody has set out to be any of the terms that you described the document in. And I think what Debbie's presentation did was begin to expose just how complicated this is. And you're absolutely right that our care needs are both health and social care needs, all of us, as we're all getting older. The specific issues that we're consulting about that are about health service changes are pure health changes in the way that Debbie's described. So that's the reason we're not sitting here with colleagues from, in this case, adult social care. But I would like to assure you, I'm heavily involved in the development of the work around integrated care communities, and I have my partners from adult social care and children's services, but in the main adult social care, working really very closely with us. Because you're right about the challenges we face, and they are challenges for them and they are challenges for us as well. And we don't think we can solve it by working independently. So the document doesn't set out how we're going to do that, but I can reassure you that in all the development work and all the work we're taking forward about how integrated care communities will operate, what we're trying to do is bring the resources together for both health and social care and plan for them at a local level so that we can make the best possible use out of it. But I don't want to be disingenuous or misleading. We have huge challenges there, and everybody in the room behind you, you won't be able to see, nodded at the points you were making about the challenge for social care, and I think it's something that we're all going to have to address together. But there is a commitment for us to address it together, and if that doesn't come across in the document, then I can only apologise. But hopefully, as we do the work with you and Kirkby Stephen and with populations elsewhere across the Eden Valley, we will be able to show you how we're being able to bring that together. But we're at the very early stages of it at the moment. So that's, I think, is your first point. Okay. The irrationality. Okay. Nobody's volunteered to take the share. Have you noticed?
Doing so well.
Yeah, thanks. Okay, I will pass to Debbie in a minute. Thank you. We all are getting older, and the facts that you've pointed out are sadly true. At some point, we won't all be here, and that is a fact of life, and we will all require care. But the work that we've done, even the folk that are using community hospitals now, when we've done the work, and my colleague David Lewis on the front of the room will be able to talk more about this as well. When we look at who's using our community hospitals now, and we audit it, over 35% of the people that are receiving care in community hospitals are not in the right place for that care. So, yes, we need a type of care in the community which isn't always somebody's home. There's a whole range of different types of facility that we should be developing. But community hospitals aren't necessarily the right place. And the work that we've done suggests that we're not supporting people as well as we might do, because some people are ending up in community hospitals when they should be better places for them to get their care, and they're spending a long time there. And community hospitals provide a fantastic service, a very good service, but we're not necessarily getting the right patients in them all the time, which is why we want to explore these other things. We'll come back to your 1 in 8 bit in a minute.
And the recruitment, yeah.
I think you've actually said most of it, Caroline, but an important bit about end-of-life care is about supporting people at end of life, where it happens over a period of time rather than suddenly, to make the choices that they want to make about where they want to end their life. So many people will actually want to be in their own homes, and part of integrated care communities is ensuring that those plans are in place to help that happen and to stop, as often happens now, people have said that they want to be at home, and then something happens, things break down, before you know it, they're in a hospital bed, and that's where they die, and that's not good for them, and it's certainly not good for their relatives and families either. So part of what we want to do is to make sure that where patients choose to die in their own homes, that they have the support to do that. And you're absolutely right that it's not appropriate in every circumstance, and sometimes patients do not want to be in their own homes, or for any other reason can't be in their own homes, and community hospitals beds may be a very good place for them to go, and that's what those beds ought to be there for, and for other particular conditions, and not for people who frankly need packages of care so that they can live independently or be in a nursing or residential care. And if you look at the commissioning strategy from a local authority, they recognise that in this part of the world we are far too reliant on nursing and residential care, and that we have got the balance wrong. And instead of supporting people at home to get better and be independent, or as independent as possible, we are moving very swiftly to putting people into nursing and residential care homes, and that just isn't the right thing to do. So their strategy fits with ours about making sure that we can keep patients fit, independent in their own homes as long as possible, and in line with theirs and their carers and families' wishes.
Everybody would agree with that.
Sorry, can you just make sure that we get it picked up on the records?
Everybody would agree with that, but you are denying the choice to people in Alston and also Maryport, who, when they do need residential care, will no longer be able to have it in their local hospital. Instead, they will have to go to Carlisle or somewhere similar.
Thank you.
I'm just going to invite Dr. David Lewis from the Cumbria Partnership Trust to answer that question specifically.
Yes, I think we've actually met and talked before, but my name's David Lewis, and I, for the last 4 or 5 years, have been one of the Associate Medical Directors in the Cumbria Partnership Trust, with a specific responsibility for the community hospitals and specifically for the community beds and the community wards. I was concerned many years ago when I first came here that, in fact, the community beds were not being used in order to manage patients from the locality. Patients were coming into those beds, and often, when they came out of the acute trust, they were further away from home than they had been when they were in that acute trust, because the beds that were available to us were not necessarily in the place that was most appropriate to them. So what's happened in the deliberations that we've been undertaking is we've been looking at the needs of beds, and we believe that we've got a figure of 102 or 104 beds, which is multiples of 8, 104 beds needed in the whole of north of Cumbria. In some of our community hospitals, it is very difficult and very fragile, and Alston is an example which has a small number of community beds, less than 8 or just 8, and it's so fragile that it's almost impossible to manage to staff those beds effectively. And in fact, we've had across the county, currently we have something like 22 or 23 beds in the north of the county which are closed due to staffing difficulties. In our smaller units, we find that the staffing problems, when you think nationally, there's approximately 9% vacancy rate for nursing staff. In some of our community hospitals, that goes up to something like 70%. And you would appreciate that that makes it almost impossible for us to manage to maintain those patients in those beds safely without risk. If you're working, 4 years ago or so, we decided to look at our staffing levels and to see whether, in fact, we were staffing appropriately for the sort of acuity and dependency of the patients that were in those beds. And we invited Keith Hurst, an eminent person who's nationally recognised, to come and do some work for us looking at that. And the recommendation that we were given based upon that acuity and dependency was that we should have one trained nurse, I think as Debbie has already referred to, one trained nurse for every 8 patient beds occupied. So the most efficient way to do that is to have an 8-bedded unit or a multiples of 8. We had sort of 10 or 11 beds, and that meant that we would have to staff with 2 nurses because it would be impossible to manage just with one. It was difficult, as I say, to recruit those nurses, but it was also quite an inefficient way of delivering the care. So looking at the success regime as we looked at the project, we came to the conclusion that we needed to have at least 2 nurses on duty in any ward at any particular time. That would give us a little bit more of a robustness as far as sickness and sudden emergency is concerned. So therefore we agreed that our beds stock would be at least 16 beds to every ward in order to achieve that. And that's when we started looking at where we have our community services. If you can just think about Alston League of Friends, and I think you might, sir, have been at the meeting that they were at as well. Alston League of Hospital Friends actually were the first to come forward with a proposal that we've considered in relation to how Alston Community Hospital and that area is managed into the future, even without beds. And it's quite interesting that it's been very positive in terms of providing more social care, more residential care, but not specifically those step-down and step-up beds that we've previously associated with the community wards. Now, that doesn't prevent them, if the GPs believe that that's appropriate, having beds available within that setting to manage patients who have end-of-life care or palliative care needs. But it does mean that they are going to take that responsibility of how they manage that effectively. And we've had 2 or 3 meetings at a high level with what's now the Alston Alliance in order to achieve that and to use that unit specifically as an integrated care community in a slightly different way. And if I can just quickly finalise on that, many of you have heard of Millham Hospital. Millham Hospital is a prime example to me of an integrated care community. It has general practice co-located in the hospital itself. It does have some beds, but it uses them in a slightly different way than it used to use them, in that it is primarily the GPs who will take on the responsibility for those patients. We have put in there with NWAS a community paramedic. We have nurse practitioners. We have staff coming from the acute hospital down in Furness. So it is an entirely integrated community service, and that's the sort of service that all our community hospitals need to be looking at to decide what is appropriate for them. But the bed stock, we've worked out, not just by plucking a number out of the air, we've worked out based on geography, upon populations and upon age of populations, how many we need in the north and the east and the west of the county. And in Penrith, I think there are going to be 24 beds in Penrith Hospital. And we're also going to be having some beds in Brampton, which is going up towards the north. So we've located those in the crucial places that we think that we need to have them in the numbers that we feel are sustainable and will not provide us with great risks from staffing shortages.
Thanks, David. If I talk about because you raised the question around recruitment and being a bit more creative. So I think it's fair to say that we've probably had, if we start with community hospitals, I think there have been problems for about the last 9 years trying to recruit into community hospitals long before I arrived. And if you think about it as a qualified nurse in a unit that wasn't necessarily designed so that you could see all of your patients because of the layout of the building, when you are the only person during the night with that responsibility, it's not like being in a big acute area where you have other colleagues that you could talk to. That, for some people, is not a terribly attractive role. So hence moving towards the having 2 people on at any one time so that you've got that sort of cover. Now, we have the most amazing people that work in our trusts who I'm sure you'll have come across across them every time you encounter the NHS, who will go do more than they are asked to do, working long hours, giving more, and we can't keep asking that of people to sustain a model that is no longer clinically appropriate. We cannot ask our people to do that. And also, if you look at Cumbria from outside, if you've been working or training in an area where they have done lots of changes, innovation, what some people call the sexy high end of the NHS, and you don't see it as part of an offering to come and work in the area, then you're not going to come and work here. So one of the big ways that we will sort out our recruitment issues is to have services that are modernised and that people want to come and work in as well. And also an opportunity where they think they can come and actually make changes to services, because that's what they're enabled to do. So on recruitment, if I talk about community hospitals first of all, we've done lots of different innovative things. People have said to us, why don't you offer more money to people to come and work here? Now, we have tried that with some roles, and I can give you 2 examples. I won't say where they were or what kind of person it was, where we offered some additional monies to come and work in the area. To one person, they said, that's great, yes, I will take the job. To the other person, they said, and these are my words, not theirs, if it is so bad that you've got to throw additional money at me, I am not prepared to come and work here. So I think we need to understand that money isn't a universal motivator here. Things that Debbie talked about, the changing of roles. So if I'm a nurse and I know that I can progress through and become a practitioner, an assistant practitioner, whatever it might be, I've got a career pathway. It's much more attractive for me to come and work here because I know I've got that development. And what it then does, if you think about the models that David was just talking about here, where we have greater GP ownership, then that might enable us to attract more GPs to the area who have specialist interests, who want to do more or different with their patients. But very specifically in community hospitals, 2 things I can talk about. One is an international program called the Erasmus program, which works. It has been working with Germany. At the moment, we're involving Italy going forward, where we have nurses from those countries who come over here during their training. They see what happens in community hospitals. They get the experience. And what we've now had are people saying, I want to come back and work here. So we've actually had, from this year's programme, 1 nurse who has said, I want to come and work in Cumbria as a result of that. So we're going out to Italy next year as well, and we'll see more of that. The other initiative is we have been collectively as the NHS going out much more to recruitment fairs and encouraging people to come to an event in Carlisle next month where they're actually going to be interviewed on the day. Both trusts are there doing these interviews. We had support again from the Joint League of Friends to fund all of this, where these people think, gosh, this is an area which really wants me to come and work for them. So 2 very specific initiatives, and one final one that I'll just headline. As you probably know, the majority of people now apply for jobs through some form of social media. And if you look at our websites, they might not be the most attractive or the most modern compared to other areas. So we've put some significant investment into that, which enables people to browse through Cumbria, to look at, well, what would it be like if I wanted to go and live and work in Kirkby Stephen? So tying up things like what happens in Kirkby Stephen, what are the house prices like, what are the schools like, etc. So people are getting a whole package through that, and not just this is a job and I'll have a look at the job and see whether I fancy it or not. So what I'm trying to reassure you is there's a significant amount of work gone in to make our recruitment practices much more modern and much more attractive.
Thank you. Thank you for a very well thought through question and for the responses from the panel. But I'm keen to hear some other voices. So there's any, yes, we've got a gentleman there, got one there and then one at the back. So we'll take this gentleman first.
Good afternoon. I'm a retired consultant surgeon from Whitehaven, and I'd like to explain really why we're sitting here. When I went to West Cumberland Hospital, it was one of the Rolls-Royce hospitals in the country. We had every facility, we had no locums, we had no difficulty recruiting staff, and the place hummed. We had x-ray reports the same night, we had pathology reports the next day. We ran a very good ship. And the rot set in the 80s when there were rumours. We're going to close that, we're going to move that. And these rumours got more and more severe. Management became much more remote. In the early days, the hospital secretary visited 3 departments every day in the hospital and asked what their wishes were and what could be done to improve it. Management became more remote until eventually invisible and moved off-site to Carlisle. As I say, the rumours spread and less people wished to apply to a hospital where they did not know what their future was going to be. Nobody in their right mind would uproot a family from the south of England to find that they had the job they'd gone to changed and staff had left. I could go on for hours, actually, but...
For the sake of brevity, please.
Brevity. The great attraction to the hospital was it's a family. The whole hospital was a family. Everybody knew each other. We had parties, we had pantomimes, we had social events. And bit by bit, this all disappeared. And we also had regular weekly meetings with the GPs. It was great fun. I blame 3 things. One is the working time directive for junior staff. No job satisfaction, no continuity. I also blame the nursing degrees. The lovely farmers' daughters, who are not all that bright, can be the best nurses. I don't just mean farmers' daughters. And then just to make a comment on the changes. Maternity services, the only normal birth is the one that's just happened. So you can't possibly send difficult births on ahead to Carlisle from Whitehaven. I think all the children's options are dangerous. I'm not qualified to talk about community care, but about general surgery. You will never attract a surgeon to a job when he's just doing hernias and varicose veins and bits and pieces and lumps and bumps. Surgery is a very challenging job, and the variety is the great excitement in doing general surgery. So unless you provide the full services back at Whitehaven as to what they used to be, and the full services in Carlisle, you're not going to get anywhere.
So, allow the panel to respond to that, if you don't mind.
I did my GP training in West Cumberland in the early 1980s, and I remember it well, and remember being on the stage in many of those pantomimes. And you're right, it did have a buzz. And but when I look, that was quite some time ago, and now I'm in my late 50s. Things have changed. Certainly, things have changed significantly in the medical workforce, and you did allude to that. It's not just a problem in rural Cumbria. The reason people have asked me why I've got a multicoloured band on, everybody else has blue. Well, this is part of a programme for covering the north and across into Cumbria, just to keep doctors in the north. So we train lots of doctors in the north, in Newcastle, and of course we avail ourselves as medical students here too. And then they go down south. Once they've qualified, or once they've had a couple of years, they move down south. Many of them came from there, and some of them didn't. And so there's a drive away from the north. There are serious medical workforce problems, and it's not just because a large amount of doctors being qualified now are females. Even the male doctors want to work on a part-time basis. They want to work set hours. They don't want to work in the conditions certainly that us can remember actually and enjoyed all those years ago. And things have changed significantly, which is partly why we have the workforce issues and the recruitment issues and the shortage issues and everything else. And it does seem as though workforce is driving us to make a lot of these changes, and in some ways it is. But then takes us back to how do we then attract people to work here, we have to offer them something different, like the old West Cumberland Hospital used to do. That's partly why I've been working with UCLan. We've been working and trying to develop a medical school in West Cumberland. We've got some medical students who will be starting there. I think it's next year, or is it the year after? We're sponsoring a local medical student who will be getting sponsored to get their degree. We're looking to work together to create different ways of attracting people to come and train here. Once they've trained here, they're more likely to stay here and work here. And you're quite right to say we're all working together to do that, aren't we? And certainly that's one of the things that we haven't done so well in the past, I would argue. But now all the HR departments are working together. We've got a package of 10 items that we can offer people to come and work in. It's not just about money. It's work in progress, though. And there's a lot more to be done. And part of the excitement of working with the UCLan is to generate that interest back in West Cumberland. We had visitors from Canada just last week or the week before who were quite bowled over with the types of things we're trying to do in terms of rural medicine.
Okay. I was also struck by, there was a comment about the safety of the maternity options. If we could pick that up as well, please.
Yeah, could I just touch before I come on to maternity on surgery and the surgery changes? When I was a junior doctor, if somebody had a heart attack, we put them into a bed for 3 days, and then on day 4 we got them up and we discharged them on day 10, and we didn't actually do much different. Over the years, technology and research has moved on, and we can now do much more. So we could provide that care still for patients, and many patients would unfortunately die either during their hospital stay or sometime shortly afterwards. Now we are really fortunate. We've got a heart centre in this part of the world at Carlisle, and so that all of the patients from West, North and East Cumbria can enjoy the better outcomes and the lives saved, we transfer patients from one end of the patch to the other so that they can have their lives saved by the heart centre. And there is good evidence that deaths have been reduced as a result of that. So if we look at the surgical changes, we know that there have been reduced trauma deaths and reduced deaths from emergency general surgery. I think I've lost my mic. Thanks. Since we've made the changes. And that reduction in deaths has been sustained year on year. When we look at it, breaking it down by postcode, the people who were most affected by those changes, the people living in the Whitehaven area and south of Whitehaven, have also had deaths reduced, even though they've had to travel further. So those changes have saved lives. And I think we need to be really clear about it. This is about modern practice and making sure that the people of West, North and East Cumbria have the same access to high-quality modern services that people do in other parts of the world. Maternity. Maternity is a really difficult one. And when it comes down to it, the really difficult decision is about weighing up the balance of risks and what is better. Is it better to plan your care to where appropriate and it is not envisaged that a birth would be normal? And I take your point about you don't always know in advance. To plan your care, to plan that at a unit which has the full components of staffing available 24 hours a day? Or is it more appropriate to give birth in a unit which is very, very fragile, has low numbers of staff and could topple over at any moment? And we know, looking at outcomes, that there are areas that we could improve across the two sites, and we need to be able to do that. So it's a really difficult balance of the risks of continuing to try to hold services together, run by temporary staff with very, very low numbers of birth and all the difficulties there are about skills maintenance and the fragility of services which could fall over at any moment, versus moving patients from one location to another. Now, this is not an easy thing to look at, and that's why we've been having maternity reviews for 10 years and have brought in all the local experts. Various people have asked us to quantify those risks. So can you put the actual numbers on the relative risks of one versus the other? We can't. Those numbers just aren't out there internationally. It is not possible to do that. So we have done what often happens when research is missing or when research can't be applied to the local area because it doesn't really take into account our circumstances. And we have brought in the national and international experts to help us look at the issues. If it was possible to deliver 2 consultant-led units, we would want to do it. Why would we not want to do it? Of course we would. But our conclusions have been that we're not sure it is, which is why we're going out to consult. But it is a very difficult one. And any proposals that people want to make that are things that we haven't already considered, then, please do so. That's part of what the consultation's about.
Thank you. So we got a question down there, and I'll come back to you. Sorry. Sorry.
Can you hear me all right?
Yes.
Right, because I got hearing aids, I can't hear myself too well. I realize you mentioned that this consultation is not about costs. Unfortunately, healthcare does involve cost. As you pointed out, there's so many £1 million going to be short unless action is taken. We've often heard comments, true or false, I don't know, about the cost of administration and management having increased out of all proportion in the health service recently, over the last years. The second point is the question of waste. I've had contacts with people who, in fact, I was married to someone who had a lifetime in the health service, and I picked up odd bits of information over that. As far as administration and management costs are concerned, it's very difficult for us to understand why there's such a lot of comment about it. Is there a waste going on by having too many people managing systems rather than doing? Okay. As far as waste is concerned, it was only this morning I was talking to someone who has a connection with the health service, and a little matter, very minor little detail. She said, why is it every time you touch a patient, you have to throw away the gloves you were using? On the other hand, when you go shopping, you have change in your pocket. You pass it over to somebody else, they pass it over, and we have grown up with an immunity to certain infections. There's far more risk in opening a lavatory door and handling change than there is in a nurse who happens to be just touching a patient here and touching another one there.
So to summarise, there are 2 questions that you're asking. First of all is about the administration and management costs.
And the other is
about the waste.
Any waste.
Yeah.
Gloves is one example. The other things, when I asked for an ambulance car, every time I ask for an ambulance car, I have to go through quite an extensive interrogation. There is details of why I need an ambulance car. If I have to have an injection in my eye, there's no question about it. Okay. Why do I have to why does the poor person at the other end worry about that?
So there's another question about information systems as well, how the records
No, that is a question of waste of time. Yes. And the other thing is ambulance waiting time. There's a whole range of ambulance waiting times, which is a waste of money again. I can give an example if you want, but it is well known that ambulances often have to wait outside A&E because A&E is full up, because the beds are full up, because people can't get out of hospital. Now, one of the things I have suggested is that these community hospitals where beds are being closed or proposed to be closed be kept open as a temporary measure as a convalescent home to get people out of hospital into a community hospital, but not as a medical bed, but purely as a convalescent bed. That would help and reduce waste of the waiting in the A&E. Thank you.
Thank you very much. Okay.
I'm going to start, but I know my colleagues are going to be desperate to come in on this one, because it's all of our favourite subject. You are so spot on when you talk about waste, and that's why when we look at our financial recovery plan, most of it is about efficiency. It's about removing the waste in our system. And we have something called the Cumbria Learning and Improvement Collaborative, run by Professor Stephen Singleton, who is well steeped in lean methodologies and service improvement methodologies that take the waste out of the system. And part of our ambition, and I really should have said something about it in the presentation, is about how we will skill up all of our staff right through to porters to be able to think about their jobs and say, I do my job and I improve on my own job. I make sure that what I do is better quality, more efficient all of the time. And there are ways to help staff do that. It's not just for one or two people within an organisation or the chief managers or head consultants to come up with that. That's something that everybody should be doing. So service improvement is absolutely fundamental to us delivering the efficiencies that we need to do. And I know Caroline and Lynn are going to want to, well, we're all going to want to wax lyrical on that one as well. The final one about management costs. Yes, management costs, it's always, why have you got so many managers up and down the country? It's not unique to this part of the world. Part of it is to do with regulatory burden. So the regulators expect so much of us now, and we spend our life, filling out bits and pieces of paper to report on what we're doing and what we plan to do and what we have done and whether we achieved it in the right time frames. So part of it's about that. But another part of our efficiencies that we're looking at in our financial plans is how across North Cumbria we can come together to do things once rather than 3 times over. So, for example, are there some of our support services that all, rather than us having one department and this clinical commissioning group having another department and the local authority and Cumbria Partnership all having their own departments, that we make some economies of scale there in order to say, because they've all got gaps as well, in order to say, how can we do things to produce more for the same or potentially the same for less money? And it's a really important part of it. That's not to suggest, of course, that we're going to be making large swathes of staff redundant. We don't need to do that. There are plenty of turnover, but we do need to make our management costs as low as possible. And that's why our financial recovery plans are all about efficiency and not about cutting services in order to generate money that we need.
Told you all, we all wanted to be part of this one, because you're absolutely right. You had a lot of things spot on there, especially the waste side of things. So although Debbie's covered quite a bit of that, part of the waste also between organisations, as patients flow through the system, things get duplicated, and that's waste. It wastes time for patients, actually does patients a complete disservice, and it is just a waste of money and effort. What Debbie said is that we're now working closer together and going to work even more closer together to try and eliminate a lot of those things. But one of the biggest wastes in the system are beds that people are in when they don't need to be there. And not only is that a waste of money, it's bad for patients. If you were at the Penrith meeting yesterday, Professor Singleton did quote the fact that if you spend an extra 10 days in a hospital bed that you don't need to be there, you effectively lose about 10 years worth of functionality in terms of muscle bulk and ability to function afterwards. And that doesn't come back. And so if you go into a bed in your 80s and you spend 10 days far too long there than you should have done, you come out as a 90-year-old. So, and therefore need more care and more help and never get back to what you were before. With that in mind, there are lots of parts, lots of components that need to reduce that waste. So it's not, so the integrated care communities will prevent people coming into hospital who don't need to be there. And there's a lot of, I already have some examples. There's things that should be done in A&E that will assess patients quicker. So ambulatory care services and the new frailty service as well that's started up will also direct patients who see a consultant very early in their treatment, get the right treatment early, get the diagnostic test early, and get back home. And where that's been done elsewhere, about 50% of those patients go back home instead of being admitted to a hospital bed. Some still need to come in hospital, quite rightly. And there's stuff done in the hospital in a better way, focusing on getting the discharges right. So there's a lot of work that we're all doing together to try and reduce that massive waste, in other words, wasted bedtime. They just finally on the gloves thing. The gloves is one probably of about 30 or 40 initiatives that were put in place to reduce hospital-acquired infections. And actually, if you take a look nationally, but certainly locally, the number of hospital-acquired infections has dramatically dropped. Number of MRSA cases and C. diff cases and others has dramatically dropped, of which the gloves thing is a small part of that.
Gosh, I've got to be careful not to get on my hobby horse now around waste, but I just wanted to talk about the administration costs. So I think we've covered some of the sort of management costs, the costs associated with running organisations. But if you think about administration costs at maybe at a lower level, in a clinical team, sometimes it's really useful to have additional administrative support, because what it then does, it enables people to get on with the face-to-face care with patients, which is what they have trained and qualified for, while some of the other things that we have to do just to maintain a service or to report back or whatever it might be. So actually adding some elements of administrative costs are really useful for clinical teams particularly. The other point about waste, we talked about the Cumbria Learning and Improvement Collaborative, and again, if we think about attraction to an organisation, one of the things that makes it attractive to stay in an organisation, because retention as well is a big waste. We might be able to recruit people, but then we lose them and we have to recruit more. One of the things that makes an organisation really attractive is where people think, they believe that they can make a difference, not just to their patient, but to the way that their service is delivered. So there's lots of initiatives going on across the organisations where frontline staff in particular have identified a waste, and they have just gone off with some support using the lean tools and techniques, and they have made those changes themselves and saved significant either time or money, or improved the service that they're able to give to their patients, or actually just made it a better team to work in because they have focused on some of these improvements. And if we become an area that is recognised as a set of organisations that believe in that kind of ethos, it will be easier to attract. So there's more to waste than just the cost.
I think we could go on about this all afternoon, and I don't want to repeat the comments that my colleagues have made, but you can see it's a combined passion. I think the only thing I would say, I'm trying to work out how long I've been in my health service career in Cumbria, and if somebody can do that, I'm a maths graduate, it can't add up. So I started in Cumbria in 1999. For me, this is the first time that organisations are working together so closely that the waste that occurs, because we've got lots of different organisations providing lots of different care where we duplicate things, whether that's clinically or whether that's managerially. This feels to me, I'm more confident now that we can do something about it, and we are putting the things in place to do something about it than I've been since however long it is that 1999 was. So you're absolutely right about waste. absolutely right, which is why, just to reinforce the point Debbie made at the beginning, if you look at the size of the financial challenge we've got, where are we taking the money out? We're taking it out, 3/4 of it through addressing waste. So you better be right, because we believe it, and that's where a lot of the financial strategy is coming from.
Thank you very much. There's a lady at the back who's been waiting very patiently, and then I will come back to this gentleman at the front. Could you just make yourself known to my colleague with the microphone, please?
This is more a comment, really, I think. It seems to me this is a national health service, and yet it's divided into all these different organisations, like the Cumbria one and Cheshire one and so on. And if you qualify as a doctor or a nurse and opt to work for the National Health Service, that you've got, seem to have a lot of choice as to where you go and how your career will go and all the rest of it. Well, it might be a good idea if part of that was experience in a rural area. And so that, you know, it seems to be led by what the doctors want and how much they want to be qualified and how far up the ladder they want to go, rather than what we need in such places as a rural area.
Okay. Thank you very much.
I also think that now we're going to have competition for the microphone again, because I think you've put your finger on something there. Part of the problem is that we've got a national shortage. This isn't just a Cumbria shortage. This is a national shortage of my particular area that I know better is general practice. But you've heard colleagues talk about exactly the same pressures in hospitals and community services. So while there is such a shortage, then people can express a preference for where they want to work, because colleagues in Newcastle, although they're not facing the same problems we've got, are still experiencing recruitment difficulties. So there is so much choice, and it's not a military service like the Army or the RAF, and you can't direct where people go, and you can't send people, though we've tried, and we have tried to get a national task force to come and bring medical support to this area. You are talking about uprooting families, and it's not that kind of employment service. But I'll give you an example about experiencing rural practice. We have just got an agreement, and our first 4 GP trainees will be starting in February. We've agreed with the London training scheme for general practice that we will be offering exactly what you suggested, an experience of rural practice. So they want to train in London. They've got successfully on training schemes in London, but the first 4 will come for a 6 months rural attachment starting in February. We've been supported. We're offering them accommodation. We've made it really attractive. We've managed to offer that accommodation because of the local community actually helping us find that accommodation, which has been great. And we hope that's the beginning of a programme that we can expand. So I think you're right, but it's not as easy as directing people to do it.
I agree with everything that Caroline has said, and I suppose we've had this question or comment before about the National Health Service. So if I'm employed by the National Health Service, why can't I be almost made to move to one area on a kind of national contract? That isn't what we are, and it isn't what we've been since, 1992, with the change in legislation there. However, if you think about it, if you think about societal changes, so I know when I first started work, I was almost grateful to have a job, and I was very happy to go wherever anybody sent me because I was going to learn things. But if you look at the way that the younger generation today, the people who are coming into work, they're looking for flexibility, they're looking for choice, they're looking for, to a great extent, something which we call portfolio careers. Which isn't that commitment long-term to an organisation. So as a set of organisations, if we can't offer things like that to people, then they're not going to come and work for us anyway. So I think a lot of this is a result of societal changes.
just to echo what my colleagues have said, but there are some things that we can do when we're growing our own. So one of the worst things is when we grow our own, particularly nurse practitioners or sort of new breeds of professionals, that they're rare as hen's teeth and they disappear off because they get poached by other patches. And of course, when you've invested a lot in your workers, then it's very disappointing after all that investment in their training and support through their training that they then go off to the nightlife in Manchester or wherever it may be. So there are some things that we can do, and I've been working with the deaneries to suggest that actually experiencing rural practice should be something which is seen as important and valuable, and not as a Cinderella, not as somewhere, oh, I don't really want to go there, or who I've been given a placement. But we've got to make ourselves attractive in order to do that. And there's also things that we can do. So I know, I don't know whether they still do it, but I know that the probation service used to, for instance, expect that if they supported you through your probation social work training in college, you then provided 2 years of service back again at the end of it. And that's something that we're also exploring for some of these new practitioners that we're developing, so that as we grow our own, hopefully after working for us a couple of years at the end of their training, we've sold ourselves as the place to come and work.
Thank you. It's a gentleman at the front here. Thank you.
Thank you very much. I'd like partly to refer back to the first question and partly to look to the future. It seems to me the document and the presentations we've had rightly accept the need for integration, but the plan, and to a degree the scope of this afternoon, has nonetheless focused on a fragment, both thematically and geographically. And we've heard, for example, the importance of the interrelationship between the social services and the healthcare services. But you've said you're not really coming here to present the way in which the social services are going to be developed. We've heard about your thinking about the provision of healthcare services in Western North Cumbria. But many of us here, as was said by the very first questioner, look to the south as much as to the north, and the integration between what happens in North Cumbria and what happens in South Cumbria and North Lancashire and over the Pennines as far as Newcastle, extremely important to people in this area, is all enormously important. And you also said, and we welcome this because we have an excellent health centre here in Kirkby Stephen, that the involvement of GPs' surgeries and the provision of better facilities there will be one way of bringing the care closer to the patient. And that's an important question when you think that if people are providing their own transport to go 50 miles to Carlisle, 50 miles back again, if you follow the HMRC rules, that's an investment of £50 of their money in the transport. So devolving more of the facilities nearer to the user, I'm sure many of us would say, is enormously important. It seems to me that there is a crucial person in this, or group of people, that also needs to be clearly identified, and it's called the patient and the patient's families, many of whom do play enormously valuable supportive roles, and patient training or patient education or better patient information is surely crucial to getting people to use the services that you're going to provide with less waste, higher efficiency, and better satisfaction, and probably comfort, enjoyment, and life expectancy all round. Please, when you have the meeting which you are going to have in the 2017, according to this document, with your colleagues in the other regions, can you think about how, when you eventually present these plans to the wider public, including all of us, therefore, you make these interfaces clear? And the document is not just a North and West Cumberland one, or one that is linked into other documents, so that people can see what the whole thing is about and be guided to use these enhanced services you're hoping to provide better, because that is really going to be the success of the whole exercise.
Can I thank you for what is an absolutely excellent suggestion? And I think could only share probably some of our frustration about some of what you're looking for. We could describe, but such is the nature of a consultation that we've ended up talking to you about what I would accept is a fragment. And a lot of what you're looking for in terms, I guess I'm going to pick up two things out of what you said. One was around how, as patients and as members of the local community, can you get much better involved in developing local services? And the second point I want to pick up is, sitting where we are at the moment, the fact that it's equally important to understand developments in the south of the county around Kendal and Lancaster as it is around Carlisle and Whitehaven, and probably far more important to understand what's happening there than it is around Whitehaven for many people in this room. The integrated care communities, which is interesting to compare to, I've only done 2 of these meetings. My first one was yesterday in Penrith, and of the 2 hours, I would guess we spent 3/4 of the time talking about integrated care communities. So it's quite fascinating how the 2 conversations have been very different. But had we had more time to talk about that, and we will have, is my point, for me and for the people that are developing that work, integrated care communities is not just about colleagues in general practice, and it's fantastic that the practice here got rated outstanding by CQC. That is truly exceptional, and they did really, really well. So we ought to just put a big tick where somebody's doing well, because we've talked about so many problems this afternoon, haven't we? It's not just about general practice, community services, the sort of services that David and Lynn's trusts provide, and increasingly support from colleagues in hospital services about what we can do locally with adult social care. Working with you as a population, as a group of local people, is just as important. So if you look at the kind of things that David was talking about that have been developed in Millom, that has been done completely in partnership with the local people in the town. We've got our most developed integrated care community at the moment in Workington, and exactly the same experience is taking place. There's a lot of involvement from people in the third sector. There's a lot of involvement of talking to people who are just using the services and want to use the services about how things should work. And it's a brilliant way of getting back to waste as well, because that's your experience is that you'll put things that look efficient from an NHS point of view, but are totally inefficient when you look at it from the user of a services point of view. That's where we need to target. So it's frustrating that we haven't had the opportunity for that conversation, and that's probably not coming across in the consultation document, but I do think we can take up your suggestion about developing that more. In terms of developments in the south of the county, there is a similar programme to this one called Better Care Together that is being developed for the services in what is known as the Morecambe Bay area. As Debbie said earlier, you always can exercise choice about where you access your care, and I know a number of people from this area choose to access services in Kendal and in Lancaster. The building block of that strategy has something called integrated care communities. So in other words, our strategies are entirely consistent across North and South Cumbria in terms of where we're building for the future. How some of the secondary care services are provided is a little bit, the proposals are a little bit different because our geographies are a little bit different, but there's enormous consistency between the two. But one of the things that we'll need to pick up, I think, through working with you more locally is to make sure that you've got as much information about what's happening there as you have that's happening in the north.
Where the real power, though, is, you're quite right, is in the local communities. So I was just thinking of patients who have COPD, which is a chronic lung condition. There's lots of different treatments for COPD, yet there's lots of other things that people can do themselves. And if you look at the evidence, stopping smoking and exercising saves more lives and improves the quality of life than any medication that I can prescribe. And just armed with that knowledge can help communities to focus on what's really important.
So yes, as Derek says, we haven't mentioned the words public health in this meeting so far, I don't think, but there is an entire strand of work going on around public health, making sure that public health is core to all of the proposals that we're putting together, and we're heavily involved with colleagues from a local authority. You'll know that public health now sits within the local authorities. We've also spent a lot of time talking about the buzzword co-production, which we've seen in practice in Millham and in other areas of excellent work, where we really do work in partnership between professionals, third voluntary sector, patients, communities, families, to develop services from scratch in the way that they need to be developed, and to ensure that they can be continually improved alongside families. We haven't done that very well so far. I think would not be stretching a point too far. There are some parts of the country which do it much better. There have been pockets of good practice locally, but we need to get much better at talking right from the start about what it is that are our challenges and how together we can address those. Because whatever happens at the end of this consultation and the decision-making process, we are all going to need health and care services, and we need to work together to make sure we do that well. I chair the transport group for, I can see you raising your eyebrows there and go, oh, right, for the success regime. And we've spent an awful lot of time looking not at ambulances, we've looked at that as well, but actually looking at non-emergency transport. And I've had some great colleagues from community transport associations, from Action with Communities, helping me get my head round actually all the things that are out there. And one of the things that we know is that particularly the east side is really, really poorly served by public transport, and we need to have much better ways to make use of our community assets through community transport schemes, through proper signposting so that it's not such a maze. Health professionals don't know about half the things available, let alone patients and families. So there's lots that we can do, and we need your help to do it.
Right, thank you very much. We're coming towards the end of the meeting. I don't want to wind it up before everybody's had the chance to speak. So does anybody have any last comments, questions, or statements that they'd like to make? Sorry, there's a lady there.
Just a comment today, really, that you might notice by looking around here that we're sort of not the youngest of the population. There isn't really a cross-section of Kirkby Stephen here, and this is obviously because of the timing of the meeting. Now, everyone who's at work can't come, and then we find it's half-term, so people with children aren't here, and that's one aspect of this that hasn't been discussed much, the paediatric proposals for the care there. So it's just a comment, really, that perhaps it's not a truly representative of our population.
Yeah, thank you for that. It's very difficult to organise those things, but I'd like to throw that to the panel too.
I think that's a really important point. However, these public meetings aren't the only way that people can get engaged in the consultation. So the consultation document itself has got a form at the back whereby you can apply. I don't know the absolute detail of all the other ways, but there's a website where people can post comments. There are all sorts of other opportunities for people to get involved in this other than in these public meetings. And I think the key thing is, any of you who've been here today, if you can talk to your neighbours, to your family, etc., and encourage them to get engaged. The first place to start, I think, would be on the website, and then they can find out all of the events, etc., and other ways of contributing to this.
It's probably worth just mentioning the chatty van. I don't know if any of you experienced the chatty van before, but it was facilitated by our colleagues in Health Watch, who have responsibilities, obviously, in relation to engagement. Healthwatch colleagues supported a van going around numerous areas, different times of day, weekends, evenings, during the engagement phase, and that's happening again now. We've also been doing a lot to identify where the groups are who might otherwise, their voices might be difficult to hear. For instance, people with mental health problems, or young people, or older single males, or elderly people who are housebound, and are thinking through all the different ways in which we can reach them so that their views can be heard. Part of the analysis that happens at the end actually weighs up all these things so that we try and make sure that it's not balanced, so that it is entirely balanced, and that we haven't got just one perspective from a particular geographical area or a particular group in terms of age or any other characteristic.
Thank you. That's a very useful point. Have we got any more comments? Any questions? So just to reinforce the importance of that, this is not the only strand of this consultation. So all the details to reinforce that are in the document, as well as the other activities that are going on. There are colleagues from Clearwater, who are the communications company, that are supporting this. They're available here. The panel aren't leaving, and I understand sometimes, or aren't leaving immediately, and I understand sometimes it's difficult to make comments in a public arena. So if you do want to make a comment, please do come forward. That takes us up to just before 3 o'clock. Last chance for questions. Okay, thank you very much. All that remains for me to say is thank you very much for the time and the passion that you've shown today. It's been really appreciated. And also to thank the panel for their honest answers to all of your questions.